Good evening, and welcome to Doctors on Call. I'm Dr. Paula Termuhlen, Regional Campus Dean at the University of Minnesota Medical School, Duluth campus, and I am your host for our program tonight on upper GI problems. The success of this program depends on our viewers. Please call in your questions on heartburn, indigestion, ulcers, gallstones, abdominal pain. We'll do our best to answer them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Amy Greminger, an internal medicine physician at Essentia Health and faculty member at the Medical School Duluth. Dr. Daniel Mckee, a gastroenterologist with Northland Gastroenterology, and Dr. Theresa Smith, a gastroenterologist with Essentia Health. Our medical students answering the phones tonight are Jake Krogstad from Iota, Minnesota, and Lillian Meyerhoff from Lindstrom, Minnesota. And now, on to tonight's program on upper GI problems. So, tonight's our last show of the year, which is why we're a little festive this evening. And we thought we'd start off with one that is a common question we've had actually over the last couple of years, which is, why isn't the small intestine examined as much as the large intestine? And if we include small intestine with like esophagus and so forth, people are used to getting those colonoscopies, but we don't do screening for the upper GI problems in the intestines and in the stomach. Why not?
Well, I think the answer to that is there is no one disease or problem that justifies doing an upper endoscopy for everybody the way there is for doing a colonoscopy for screening for colon cancer. Mm-hmm. I mean, everybody should get colonoscopy for colon cancer screening at age 50 or maybe a different age depending on risk factor issues, but that's appropriate for everybody. Mm-hmm. And while there are certain cancers that we screen for in certain selected individuals with upper endoscopy, there is no cancer that is appropriate to screen for in everybody, and I think that explains the difference.
And some of it is the commonness of colon cancer. It's really the second leading cause of cancer death in the United States. It's a very common cancer, mm-hmm. where cancer of the esophagus, stomach is much less common. The other thing with colon cancer is there's a precursor lesion, polyps, or they're often benign, but they can over time grow and lead to colon cancer. So with colonoscopy, we're looking for these precancerous polyps that we can remove. Cancer of the small intestine is extremely rare, and so it's usually only in very specific cases where we would screen for that.
Well, so what in your practices, what do you see as the most common reason someone may come in and need to have an examination of their stomach, for example?
Oh gosh, there are a whole bunch of reasons. Abdominal pain, trouble swallowing, long-standing acid reflux symptoms. Sometimes it's part of the workup for anemia, iron deficiency anemia in particular. Those would be some of the more common reasons for an upper endoscopy.
Well, our viewers are calling in, and so that's really exciting. We've got some questions. Well, let's start off, since we're talking a little bit about the stomach and reasons someone might have it examined. We've got a caller who'd like to know what causes esophageal varices. So maybe explaining what those are to start with, and then thinking a little bit about some of the treatments for it.
Well, esophageal varices are dilated veins in the esophagus. Just like you can get varices or varicose veins in your legs, you get varices, these dilated veins in the esophagus. The most common cause for esophageal varices is liver disease, and it has to be fairly severe liver disease, generally cirrhosis of the liver. All the blood in your body has to go back through the liver to get to your heart. And if the liver is scarred and hard, then that blood has difficulty getting through the liver and finds other pathways of lower resistance to get back to the heart. And unfortunately, the esophagus is one of those places. When the pressure gets too high in those veins, they can rupture and bleed, and that's a very serious thing. About 10% of people who have variceal bleeding will not survive an episode of variceal bleeding. So we actually screen for varices in people who have cirrhosis of the liver. We'll do an endoscopy where we look down, and if they have varices, there are two different things we could do. We could start medication to decrease the pressure within the veins, or sometimes we will do what's called esophageal banding, where we put a little band around the varix to basically kind of cut off the blood supply, which leads to an ulceration and some scarring. It sometimes takes repeated procedures and banding to scar down all the varices, but that's the general approach.
Okay. Well, so we also have another call now that we'd like to take a little different direction. Question becomes, or should I be taking a probiotic or a prebiotic, and how frequently should I take one of those? So lots of questions about that. Dr. Greminger?
I will say that I commonly end up putting patients on probiotics in a very specific circumstance. When I'm putting people on antibiotics, I tend to recommend probiotics a lot of the time. And the reason that I do that is because a lot of the antibiotics can change the way the flora is in your gut. And so the probiotics help to balance that out. I don't know that I necessarily usually recommend for my patients to take probiotics all of the time. I think it kind of depends on the person and the circumstance. But that is one thing that I've commonly encountered in my practice, specifically around antibiotic use. What about you guys?
Yeah, I think there are some specific uses for probiotics where they've been shown to be helpful. Certainly in folks with a certain type of infection called Clostridium difficile, it's helpful. Probably helpful for some folks with irritable bowel syndrome, and there are a few other less clear indications, but there's an awful lot of advertising suggesting that everyone should be on a probiotic and or prebiotic for so-called gut health. And there's absolutely no justification for that whatsoever. They won't hurt you, but they don't provide any benefit, and so it's basically a waste of money in that situation.
Sounds like one of those things to talk over with your doctor. Well, so we're now starting to get a few other questions on heartburn, and sort of in the theme of both the sort of prescribed medication ways of treating heartburn, but then also are there other non-medical ways or natural ways that we can address heartburn? So, Dr. Smith?
Yes, there certainly are, and when I'm treating heartburn, I like to start with lifestyle modifications first, because that often can be effective and the individual can avoid taking medications. So lifestyle modifications would involve changing your diet, maybe avoiding caffeine, even decaffeinated coffee and some herbal teas can sometimes exacerbate reflux symptoms. Avoiding chocolate, peppermint, onions, garlic. So there's a whole list of foods that it might be best to avoid. Certainly keeping your weight down can be very effective in treating acid reflux disease. And then certain things like not exercising right after you eat, not eating and then going to bed, go to bed with an empty stomach rather than a full stomach. Some people who have a lot of difficulty at night benefit from raising the head of their bed so that they're still fairly flat in bed but at an angle, and gravity can help keep fluid and the gastric liquids in the stomach. So there's lots of things lifestyle-wise that can be done, and then if that's not working, then you would consider adding medication.
So what kind of medications do you usually prescribe, Dr. Mckee?
Most medications that we use are some type of acid suppressant. The only time I guess we'd use something lesser like an antacid would be for infrequent heartburn symptoms, but by the time they get to see a gastroenterologist, they are folks who have really significant symptoms. So acid suppressants fall under two general categories, what we call H2 receptor antagonists. Those are things like Zantac, or proton pump inhibitors. Those are the medications like omeprazole, Prilosec, Nexium, which are stronger acid suppressants. And which to use, I think, kind of depends in part on patient preference and how severe the symptoms are. The proton pump inhibitors, like I said, are stronger acid suppressants, so with someone who has maybe more frequent symptoms, they're appropriate.
Is there any problem with being on them for a number of years or taking them with on a regular basis for a long period of time?
Yeah, that's a great question. There was a lot of concern a year or two ago, especially with the proton pump inhibitors. And some information came out suggesting a number of potential harms associated with drugs like Prilosec. And then there was a push to back off on the use of those medications. And a more recent, better study has come out, which I think is the definitive answer to that, suggesting that with the exception of an increased risk of small intestinal bacterial overgrowth, which is excess bacteria in the small intestine, those earlier expressed concerns are ill-founded and not an issue. So the proton pump inhibitors are really quite safe for long-term use. The other issue that's been in the news lately is the concern with Zantac, ranitidine. There's a generic manufacturer of ranitidine in India that has had their product contaminated with a carcinogen. And I know I've had a number of questions from patients, I'm sure Dr. Smith has too, about whether or not it's safe to use ranitidine because of that. And just recently, some pharmacies have been pulling that off the shelf. But there's plenty of ranitidine that's manufactured elsewhere, so, or you can just switch to a different similar medication, different H2 receptor antagonist. So.
Yeah. So, Dr. Greminger, I know you take care of a lot of older patients. What's been your experience with heartburn symptoms?
I think I definitely have a lot of patients that are elderly that have issues with heartburn, and many of my patients are on some sort of chronic medication for heartburn. Very often omeprazole or something in that category of things. I think that a lot of the very same things that Dr. Smith mentioned are risk factors for our patients who are elderly. A lot of times they are laying down soon after dinner. Certain other things like alcohol can relax that esophageal sphincter, so if people are having a lot of issues with it, I might caution them that alcohol might be best avoided as well. And yeah, I think over time people tend to develop a lot of issues with heartburn as they age. Not necessarily, not for everybody, but for some.
Oh. Well, very excited that we do have folks calling in. So we have William from Hayward who asks a really specific question, which is, what is the composition of Endoclips? How, where, and when are they used? And could they result in fistulas?
That's a great question.
Yeah.
Well, Endoclips are little metal clips, usually made of titanium, that are used to close defects in the intestinal tract, usually where a polyp has been removed in the colon, but they could be used in the stomach to stop bleeding or to treat some other, generally bleeding in the stomach. They typically will fall off in a week or two. And I am not aware of any cases of an endoclip causing a fistula. Not to say that it hasn't been reported, but I am not, I don't know, are you aware, Dan, of any
No, I'm not,
cases
and I don't think it would, because to cause a fistula, it really would have to penetrate through the muscle layers, and the clip grabs just onto the superficial layer, the mucosa. So if it's happened, it has to be unbelievably rare, but I would guess it can't. I wouldn't think it really is possible.
Yeah, I mean, the only kind of theoretical way I could think of that it could happen is if it was used in a colon that had a lot of diverticulosis and it was within a diverticulum, and sometimes we will put them in there if there's bleeding from the diverticulum, but even that I've never seen it happen, and I think it would be exceedingly rare.
Yeah, and in surgery we use them to internally, of course, and they actually are left behind very frequently on purpose to control bleeding and for a variety of other reasons. So, okay. Sue in Duluth has a question related to autoimmune diseases and how that might damage intestinal walls, and if a healthy diet or lifestyle can decrease the cancer risk and maybe even help the autoimmune diagnosis. So I think really the idea here is thinking a little bit about how do autoimmune diseases relate to intestinal concerns, and can there be lifestyle changes that might make a difference? So.
Wow, that's a lot of question.
There's a lot there, yeah.
That's for
Well, there
sure.
are a lot of autoimmune diseases, a lot of digestive autoimmune diseases, and with respect to intestinal autoimmune diseases, there are a bunch. But speaking in general, generally diet isn't the approach of treating autoimmune diseases of the digestive tract. The treatment is some type of immune suppressing medication. And so, generally speaking, I would say diet doesn't play much of a role in treating digestive autoimmune diseases.
Yeah, I can think of two exceptions. One would be celiac disease, which we kind of think of as an autoimmune disease, but it's more really like
Almost more of an allergic disease.
like an allergic disease.
Not really so much autoimmune.
And that's where people will avoid gluten, products
Correct.
with gluten often.
Correct,
Yeah.
right. Right, and celiac disease is a very specific disease where people will develop damage to the small intestine if they eat gluten. There are a lot of other people who may have symptoms if they eat gluten or too much gluten, but they don't necessarily have celiac disease. But someone with celiac disease would need to avoid gluten. The other thing I can think of is something called eosinophilic esophagitis, where people develop inflammation of the esophagus, and there's some evidence that that can be associated with certain things in the diet, and an elimination diet is sometimes helpful in treating that, but oftentimes it also needs to be treated with medications. So hopefully that answers her question.
Sure. So, LaDonna in Duluth has acid reflux, but doesn't have the symptom of heartburn, but she has to clear her throat. And so how does that work? In other words, I think this is really a question that gets at the heart of the constellation of symptoms that you might have if you have that acid coming up.
So one of the things that you do consider in a differential diagnosis, or when you're thinking about things that might cause a chronic cough, is certainly acid reflux. That if there's acid that's kind of in that system, it can irritate the throat and cause some irritation and then have a cough reflux, or cough reflex. And so certainly that is very possible for reflux. And if that's what's causing the symptoms, typically proton pump inhibitors or some of those other medications are helpful for patients. I don't know, what are your thoughts?
Certainly that is a common cause of chronic cough. There are other causes too, of course, and you can try proton pump inhibitors. One problem, though, is unlike heartburn, the common classic symptom of reflux, sometimes when folks are having a chronic cough, the cough isn't necessarily due to acid. When you reflux, you're refluxing lots of things besides acid. I mean, there's a whole soup of nasty things in your stomach that you can reflux. Enzymes, bile, partially digested food, and acid. And a medicine like a proton pump inhibitor just takes the acid out of the soup, but it doesn't take the rest out. And so you're still refluxing that other material, which could allow the cough to continue. So in that case, lifestyle sorts of changes, like Dr. Smith discussed earlier, might be more beneficial than simply using an acid suppressant.
Okay. Well, so let's talk about the stomach for a minute. We have a couple of questions. One viewer would like to know, how does stress cause stomach ulcers?
That's a good question. We used to think that, and this was a long time ago, that emotional stress could cause ulcers. And then it was discovered that there's actually a bacteria that is a fairly common bacteria called Helicobacter pylori that is the primary cause of stomach ulcers in people who are not taking medications that cause stomach ulcers. Aspirin and other non-steroidal anti-inflammatory medicines like ibuprofen can cause ulcers as well. So we really have gotten away from the belief that emotional stress can cause ulcers. There is something called a stress ulcer that can occur in the stomach that is seen in patients who are extremely ill and usually in the intensive care unit after a bad burn or a major accident with lots of surgery. And that's different. That's probably an ulcer that forms due to lack of blood flow. But the thinking that being nervous or anxious or having some emotional stress causes ulcers has really kind of gone away. We don't believe that anymore.
Good. So here's another question related to the stomach. Does eating red meat cause stomach cancer? I know I've heard that mentioned years ago.
Yeah, no, I don't think so. I don't think there's been any good association between red meat and stomach cancer. There are some foods that are associated with stomach cancer. If you went back years and years ago, before, the 1940s, when refrigeration wasn't common, stomach cancer, gastric cancer was the #1 cancer in this country. And the reason was that without refrigeration, most foods were salted or pickled to make them last. And that resulted in the formation of carcinogens called nitrosamines. And so salted and pickled foods are carcinogens. For example, bacon is a type of food that you'd commonly eat today that is not good with respect to stomach cancer. But a hamburger, a steak, not so much. That's probably okay.
And an occasional piece of bacon is not going to hurt you.
Absolutely.
Either, right? Yeah.
That's right.
We'd be disappointing a lot of our viewers, I
Yeah.
think.
Yeah.
So Dr. Greminger, I have a question for you, because I know you and I were talking about this earlier today. Apple cider vinegar, can it relieve stomach indigestion? It seems to be a popular sort of thing that people are buying these days to help their digestive health.
So I don't think that there's a lot of good randomized control studies on that particular data. Certain people do think that it may help for reflux symptoms potentially. It's an acid, so it could also exacerbate some of that. So I'm not sure where the evidence comes down exactly. The best thing I can say is it kind of is. I hate to tell people that anything can do anything, but it really the reaction that you have to it is very individually based. There's not a lot of good evidence that it's helpful or harmful. Strong acids can reduce enamel on teeth, so if somebody was trying to take it medicinally, typically it's recommended to dilute it.
Okay. Bridget has a question asking about small intestine bacterial overgrowth. So we were talking a little bit about bacteria here. How can you get rid of it? But I think the real question is, do you need to get rid of it, and how does it start? And I know there's some procedures that we do surgically for patients, particularly those that may have had intestinal rearrangements, sometimes things that we've done, operations that we've done to help reduce obesity, so morbid obesity surgeries. But what has been your experience with bacteria, the intestinal bacterial overgrowth?
Well, oftentimes it is seen in patients that have some kind of altered anatomy, but it can happen in people that have not had any surgery and don't have any change in their anatomy. Typically the symptoms are a lot of bloating and diarrhea are the usual symptoms. There are tests that can be done. The most common one is a breath test, where we give the individual a non-absorbable sugar, and then we measure how much hydrogen and methane they produce in their breath. So that's one thing that you can do to try and make the diagnosis, but oftentimes it's easier just if clinically it seems like that's very likely the problem, to give a course of antibiotics. Usually a 10-day course of antibiotics will resolve the symptoms. There are some patients, especially the ones that have some kind of altered anatomy or altered motility, like perhaps an individual with scleroderma, where you might have to do repeated courses of antibiotics.
Yeah. So we've only got a couple of minutes left, but here's a question I think many people wonder about is there a relationship between your gut health and your mental health?
I think we're recognizing more and more that there is a link. There are as many or more nerves in your digestive tract as there are in your central nervous system. And the same neurotransmitters that exist in the brain and in the spinal cord exist in the digestive tract. So there is a connection, and we know that with functional digestive diseases like irritable bowel syndrome and functional dyspepsia, that controlling the levels of those neurotransmitters can control symptoms. So more and more we're learning that there's a so-called brain-gut connection. Whether or not there's a gut-brain connection to the extent that if you control digestive diseases, it will affect mental health other than what you'd expect just by making someone feel better. I'm not sure about that. I'm not sure that that's been established yet. But there's definitely an interconnection between those two different nervous systems and the neurotransmitters between them.
I had heard at one point there was a connection perhaps between depression and the inflammatory bowel disease spectrum, but it doesn't sound like that's been fully fleshed out. So, all right. Well, we're getting close to the end of our show this evening, and I really want to thank our panelists, Dr. Amy Greminger, Dr. Daniel Mckee, and Dr. Theresa Smith, and our medical student phone volunteers, Jake Krogstad and Lillian Meyerhoff. Doctors on Call will be off the next 2 weeks for the holidays. Please join Dr. Steve Vopat on January 9th when we will be back from the holiday break for a program on lower GI problems. His panelists will be Dr. Yanni Hillman, Dr. Theresa Smith will be back, and Dr. Arnie Vigno. Thank you for watching. Happy holidays and good night.